limited setup if we follow certain specific steps. So be careful. The next woman walking in your OPD with a breast lump could well be a case of suspicion. When I teach my students, I say, if you are treating a patient and if you are not able to find an answer after 3 weeks of treatment, do give a thought that the patient might be having an underlying malignancy. Take a thorough history, including a family history, a good family history on both sides of the patient. Do a detailed local and systemic examination. So what are the common presenting features of breast cancer? A palpable breast mass is by far the most common symptom with which almost 90% of the females will present to you. Some of them will be having an associated nipple discharge. Uncommonly, a female might be having an axillary lump without a palpable breast mass. Those patients also can be harboring an underlying occult brain breast malignancy. A non-being ulcer can present as Paget's disease of the nipple. In advanced cases, you might see a floating ulcer over the breast or axilla. And very, very rarely, especially in our countries, a patient may come with an abnormal mammogram report to your clinic and said, Dr. Saab, I have been diagnosed as BIRATS 4 on a mammography report. I have no complaint. What should I do? This is more common in the Western countries, which has over 90% screening program adherence in women. So when we talk about breast mass, the first job of clinician is to assess whether the mass he or she is dealing with is benign or malignant. There are few simple pointers here which indicate whether it's a benign mass or a malignant mass. We all have read this in our undergraduate times. The age of the patient would be generally less than 40. The benign mass is firm to soft-in consistency. It is usually freely mobile, generally associated with pain. Now mind it, cancerous lumps are usually painless to begin with. And the common perception amongst patients is that अगर pain नहीं है तो cancer नहीं है. That is an important thing that we need to understand. In fact, painful masses are more likely to be benign. The benign mass generally changes its size with menstrual 40 years of age, which she has a hard lump which is difficult to move. Usually it is painless. It remains fixed in size or more alarmingly increases in size with time, associated with systemic symptoms like nipple discharge or weight loss. These are the red flag signs that indicate that the lump you are dealing with is more likely to be malignant. So once you get a patient who comes to you with a breast lump, so the simple algorithm that you can follow in order to achieve a diagnosis. This is copy pasted from Harrison. I have done a small modification in between in order to suit our setting of practice. So if a female comes to you and if you are not sure, usko mark back. We all are not, no. But when you are sure, okay, that there is a mass, the first investigation that I would advise is to do an ultrasonography of the breast. The reason is it will categorically tell you whether it's a solid mass or a cystic lesion. Cystic lesion is unlikely to be malignant. It's less than 5% chance that a cystic lesion is malignant, whereas a solid lesion has a higher probability of being malignant. Once you diagnose the lump is solid, the first and foremost investigation you do is to get a good mammogram. Now, I understand getting a good mammogram is a challenge, but try and find a good radiologist and a good mammography center, because this is the most important initial imaging in breast. It has both diagnostic and therapeutic implications. It should be done before any attempted biopsy or FNAC. Always obtain a bilateral mammogram. Obtaining a unilateral mammogram is taking an X-ray of half of the chest. And most importantly, get it reported from a good center. Now, what does the mammogram show? First and foremost, it will show you whether a mass lesion is present or not. It will tell you about the calcifications in the mass lesion. The pattern of calcifications are important because the pattern of calcification in malignant mass are very characteristic. It will tell you about the density of the breast tissue, whether the skin is involved or not. It will also tell you whether the pectoral muscle is involved or not. It will tell you about axillary lymph nodes, and most importantly, it will tell you the condition of the opposite breast. Now, mind you, less than 5% of females have bilateral breast cancer. So somebody who comes to you with the right breast lump, that doesn't mean she is cancer free from the left side. An ideal mammography report is reported in terms of BI-RADS scoring. A well-reported mammogram, if it is reported as BI-RADS category 1 and 2, you can be rest assured that the mass is non-malignant. It is likely to be due to benign conditions like fibroadenoma or fibrocystic disease. Category 3 is a gray area, it is borderline area. That is where the clinician has to take a call. How much is the possibility of this BI-RADS 3 lump being malignant, and depending upon that, he or she can advise for biopsy. Whereas category 4, 5 are highly suspicious of malignancies and certainly should be proceeded with further evaluation. So what are the therapeutic implications of mammography? We have just discussed the diagnostic implications. The therapeutic implication is that it establishes the diagnosis of malignancy. It will help you guide the site of biopsy, because whenever you are doing a biopsy, ideally you take the biopsy for highest field from the areas where calcifications are present. Importantly, mammography is a very important test that will decide the eligibility of a female for breast conservation surgery. It will tell you the status of the opposite breast, and mammography is an approved, proven screening test for diagnosis of breast cancer. The next important thing that you need to do is get a biopsy. Now, this is the most important diagnostic investigation. It is important that you obtain a good chunk of tissue. There are three types. It can be true cut, incisional, or excisional. Commonly, true cut is preferred. It can be done as a blind procedure or under ultrasonographic guidance. And doing a breast biopsy doesn't upstage the tumor. An important line you have to mention is an FNAC is not adequate to establish the diagnosis of primary breast cancer. You need a biopsy for that. Why do we need a biopsy? Because it will tell you whether the underlying malignancy is invasive or not, which an FNAC will not tell you. It will tell you about the histological subtype, which has prognostic significance. It will also tell whether there is an underlying associated intraductal component there or not. You can come to know about the grade of the tumor, which again has prognostic significance. And when we do the markers, that is ERPR equal to, you cannot do it on an FNAC, you have to do it on a tissue or a biopsy. And going forward in metastatic settings, nowadays we do a lot of molecular and genetic testing, for which we do require a tissue and which cannot be done on an FNAC or a cytology sample. So to summarize the diagnosis, you take a good history, a good clinical exam, get a mammography done, and get a biopsy done. That's it. Follow these three steps and you will be convincingly establishing a diagnosis of breast cancer. Second step is staging. Basically, staging means how much the disease has spread in a human body. There are two types of stage. One is the clinical stage and one is the pathological stage. We will discuss that later. Now, if you see the textbook TNM staging, you know it is slightly complicated and difficult to remember on day-to-day clinical practice. Size less than 2 cm, 2 to 5 cm. For a clinician, I would say just remember these three stages. We can categorize your patient as either early breast cancer, locally advanced breast cancer, or metastatic breast cancer. The easiest one is metastatic breast cancer. If any type of metastasis is present, the patient automatically becomes a metastatic breast cancer. For early and locally advanced, remember if axillary nodes are palpable, if axillary nodes are present, most of the patients will be locally advanced. Most of the patients with the palpable axillary nodes will be locally advanced. Only those patients whose tumor size is less than 2 centimeters with a palpable axillary node will be early. Apart from that, everybody will be a locally advanced breast cancer. And patients with no axillary nodes and tumor less than 5 centimeters will be early breast cancer. This is a simple rule with which you can actually remember the staging, whether it is early, locally advanced, or metastatic. Now, when we do staging, we need to do scans for the patients. Okay, so when do we decide which patient has to undergo a scan? It's not like we start prescribing scans for every patient walking into our clinic. So that's where I said there are two types of staging. One is the clinical stage. Now, when we examine the patient, we discern the clinical stage of the patient. Now, if on clinical examination the patient is an early breast cancer, suppose she has a lump which is less than 5 centimeters without axillary lymph nodes, then she is a case of early breast cancer. And she does not have any systemic symptoms. There is no weight loss, there is no bone pain, there is nothing. Lab reports are normal. Your routine CBC, alphas, everything is normal. Then there is no need of doing a systemic imaging. These patients do not warrant a systemic imaging to diagnose metastasis because the probability of diagnosing occult metastasis in these patients is less than 5%, which doesn't warrant or which doesn't justify prescribing expensive scans. But for practical purposes, we do a chest X-ray and an abdominal ultrasound. For locally advanced breast cancer patients, it is mandatory you do a systemic imaging, irrespective whether symptoms are present or not. So for all locally advanced as well as metastatic patients, you have to do a systemic imaging. Now somebody might ask, patient already metastatic, why do we need to do a systemic imaging? You already know it's a stage 4 disease. The thing here to stress is that once you treat the patient, you need to decide whether the patient is responding to the treatment or whether he or she is progressing on the treatment. For that, you will require a baseline image to compare with. That is why, irrespective of metastasis, you need a baseline imaging. What imaging do we do? So, if there is no financial constraints, the ideal imaging to be done is a whole body PET CT because studies have shown that PET CT upstages the breast cancer by 25% compared to a conventional contrast enhanced CT. If you have limited finances, get at least a good contrast CT chest, abdomen, and pelvis with a bone scan. And if there are absolutely no finances, then at least get a chest X-ray, sonography of the abdomen, and a skeletal survey. Anything below this is certainly not acceptable. Regarding the third part, treatment, it should always and importantly be carried out at a tertiary care center. Obviously, because the results are directly proportional to the experience of the center, it always involves a multidisciplinary team right from the outset, including bare minimum a surgical, medical, and radiation oncologist. Treatment is best done by qualified oncologists, and the options of clinical trial should always be kept open because it's a continuously evolving branch. In a nutshell, if we see the treatment, if the female is a case of early breast cancer, surgery is offered upfront, and after surgery, when the entire specimen is removed, then we stage the patient, and that stage is called as pathological stage. And here we come to know the two different types of stages. One is the clinical stage, and one is the pathological stage. So when patient is offered surgery upfront, the entire large sample is removed, testing is done, pathological stage is established, and based on the pathological stage, it is decided whether the patient requires chemotherapy or radiation after surgery or not. In case of locally advanced breast cancer patients, patient usually will require all the three modalities of treatment. She will require both surgery, radiation, and chemotherapy. And most commonly, the recommendation is you give chemotherapy first to these patients and do not subject these patients direct for surgery. There are studies which have shown that patients who receive surgery first followed by chemotherapy versus chemo followed by surgery, the results are better with chemotherapy followed by surgery in locally advanced breast cancer patients. So in locally advanced breast cancer, they will receive chemotherapy upfront. Post completion of chemotherapy cycles, they will undergo surgery. Mandatorily, they will undergo radiation because they are locally advanced, and then hormonal therapy for 5 to 10 years depending upon the hormone status. For a metastatic breast cancer patients, there is very limited role of surgery and radiation, and these patients are mainly treated by chemotherapy, hormonal therapy, targeted therapy, and nowadays immunotherapy. Surgery and radiation mainly is done with, for palliative intent, for palliation of certain specific symptoms. Now, if you see the cure rates for stage 2, the survival rates is somewhere in the range of 75%, whereas in stage 3, the cure rates go down to up to 40 to 60%. Metastatic patients, the final survival rate is dismal, less than 5%. So to conclude, breast cancer is a common cause of mortality amongst Indian women. Cure rates are extremely high for early breast cancer patients. Breast is an organ that lends itself for easy examination so that it can be diagnosed early and easily. Non-oncology practitioners do have a pivotal role in picking up the cases at an early stage. And one should not be scared if he is confronted with the diagnosis of breast cancer. With the systemic approach, even in the resource limited setup, you can offer a lot more to your patients than you think. Thank you for your patient hearing. And I'll be happy to take any questions.
Thank you, Acharya, for this wonderful and very clear presentation. And now, for questions.
I have a very simple question. Why US US is very
Sometimes people sometimes people do because if the lump is very small, it can be considered, but majority of the times it's a blind process. You can easily palpate the lump and get it done.
all the Islam, all other then another query is compare the mammogram because here
Yes. A mammography and an ultrasound select what is an apple, average, and orange. Each has its own importance. But in case of diagnosing a breast cancer, the importance of an ultrasound would be to mainly distinguish between a solid and a cystic lesion. I would not go beyond that. I would not go beyond that because you require excellent sonologists to actually tell you whether there is vascularity in that tissue, in the lump, whether there is septations or whether there is calcifications. You require a very good sonologist to tell you that. So in the resource limited setup, if my sonologist this lesion is cystic and this lesion is solid, I am more than happy. Whereas mammography is much more important and it gives a lot of information compared to sonography. It will actually give you a diagnosis of breast cancer. So if there are calcifications, there is a very high chance that this lump is a breast lump. That's why the category of BIRADS come into play. Secondly, a surgeon who is deciding on performing a breast conservation surgery cannot do a breast conservation surgery without the inputs from a mammographer. It is just not possible because what happens is up to 10% of the breast cancer cases can be multifocal. So if you are doing a breast conservation surgery, you will be removing one quadrant, whereas there will be an occult malignancy in the other quadrant. So mammography gives you a lot of information both in terms of your diagnosis as well as planning your treatment. That is why I said in my slide, it has diagnostic as well as therapeutic information.
yeah, thank you, sir. This question I raised just I saw that some rooms they and we trying
Cousins from other countries like Australia, those days it was not a consensus even that time also. But most of the surgeons they said the good pathologist. You could rely on FNPC to carry out your plan of action. Like, but nowadays, as you have said, FNPC has got almost no role. I think. I want to know is does FNPC upgrade the tumor as in renal cancer or testicular tumor?
For breast cancer, as I said, either biopsy or FNC doesn't upgrade or doesn't upstage the tumor. There are certain malignancies in which we do not do a tissue for the fear of upgrading, but in those cases we strictly doing the tissue diagnosis. But in breast, there is no such issues. And the role of FNAC, if I may just stress on that, in today's time, the role of FNAC is probably restricted to a scenario where I have a patient with locally advanced breast cancer and there is a single doubtful lesion, not malignant, and it is a benign lesion. There I would advise an FNAC from that side. Apart from that, FNAC doesn't have much of a role to play there.
There is in that poster there is BRCA. I think you didn't mention about that. Do you carry out this test BRCA?
So BRCA mutation testing, that's a topic in itself. So generally, if you see up to 5 to 10% of breast cancers are hereditary in nature. Okay, and in those hereditary breast cancers, 90% are due to BRCA1 or BRCA2 mutations. So there are set guidelines which tell us in which patients you are supposed to do a genetic testing. The word is genetic testing, not BRCA testing. So there are specific set of guidelines. For example, somebody who is of Ashkenazi Jewish origin, a female who is diagnosed with a breast cancer who is less than 30 years of age, somebody who is diagnosed with a bilateral breast cancer, somebody who has a synchronous or a metachronous breast and ovarian cancer. These patients, or these are the indications in which we do a genetic test. So when first you establish this patient requires a genetic test, then we do a genetic counseling. Ideally, that has to be done by a qualified medical geneticist, wherein he or she will take a detailed family history from both sides for up to 3 generations. They will try and find out what is the possible syndrome this patient inherits. Because there might be one patient who has developed a breast cancer, somebody who has developed a colon cancer, somebody who has developed a brain cancer. So depending upon how many relatives are affected, what type of cancer they have got, and what is their age of diagnosis. Based on all these inputs, a medical geneticist decides, okay, this patient might be having hereditary ovarian and breast cancer syndrome, or this patient might be having a hereditary non-polyposis colorectal cancer syndrome. Then, once we have a rough idea, we do what we call the germline testing for BRCA1 or BRCA. If I think that this patient has a BRCA mutation, we will be doing a germline testing for BRCA1 and BRCA2. So basically, it's a simple test. You get the peripheral blood, and the mutations are seen. The pathological mutations are present in BRCA1 and BRCA2. Then the patient is categorized as a hereditary breast and ovarian cancer.
My last question. If mother is breast cancer positive and the elder sister is also positive, and then the younger sister has a strong feeling or some concern for development of breast cancer in future, what is the status of mastectomy? This.
So, situations. One, when there is a proven hereditary breast cancer syndrome, which can be BRCA positivity, which can be CDX1 positive. There are a large number of syndromes which will expose to breast cancer. So, if somebody has a genetically proven hereditary breast cancer syndrome, she can be offered other options also, varying from prophylactic mastectomy, but she can be on prophylactic mastectomy.